Hey guys, this is the first video of the upper extremity, mainly talking about the overview of the bones and the joints and the muscles, nerves, arteries, veins, and including some muscle conjectures that will help in all the rest of the muscles we talk about this year. So let's jump into the video. Again, this is a video covering this first section. There are, in this section in your packet, I talked about bones, joints, and joint types that you can label here on this diagram. I'm going to do some of it with you pretty fast. Metacarpal bones you find in the palm. Carpal bones are in your wrist, so those are the wrist bones. Phalanges are your fingers, and there's 3 different sets: proximal, middle, distal. Your glenoid fossa, you don't really have to label that as a bone. Your glenoid fossa is on your scapula. So even better would be to say scapula here. You find your ulna on the medial portion of your forearm, radius, your humerus, and so you have 32 bones in all, including some practice bones for the carpal bones. Again, in the packet, I have a flipped diagram where your blanks are left hand, your answer key is right hand. So the scaphoid starts here on the left, where it starts on the right over there. Your lunate is there, where your lunate is here. So feel free to practice that. And you also find many joints, and these are the names of those joints in your upper extremity. From your glenohumeral joint that you find between your glenoid fossa and your humerus, so between your scapula and your humerus right here. That's usually what we think of as the shoulder joint, the one that's the most flexible and the least stable. All the way down to your IP joints between your phalanges. These are your interphalangeal joints, IP. Sternoclaviculars between your sternum and your clavicle, right up here. To your acromioclavicular, and that you'll find between your acromion process and your clavicle. So you'll find that right there. You're going to have a separated shoulder is what we talk about when you injure that area. That's between the clavicle and the scapula. The acromion process is a landmark on your scapula, so acromioclavicular. Your humeral ulnar is really your elbow joint. That's the main articulation in your elbow, is between your humerus and your ulna right here. Ulna is way bigger in the proximal portion. You also have your radio-ulnar joints, your proximal radio-ulnar joint, which is right here between the radius and the ulna, and the distal radio-ulnar joint, which is right here. You also have your radiocarpal joint, because the main bone in your forearm that articulates with your wrist is your radius. So this is your radiocarpal joint right here. We usually call that the wrist. You also have your CMC, your carpometacarpal joints. One is special. The number 1 CMC joint, carpometacarpal, is your saddle joint right here. But you also find other kinds of joints over here between your carpal bones and metacarpal bones. You also have your metacarpophalangeal joints between your metacarpal bones and your phalangeal joints, and there are 5 of them, and they're right here. So there's a ton of joints. Those are the names. The ones you can see, if you guys want to pause this and look at this. Scapulothoracic is one I didn't mention in the last slide. So scapulothoracic is a joint between your scapula and your rib cage. On this slide, you see a zoomed-in picture of those 4 joints: your acromioclavicular joint, your scapulothoracic, your glenohumeral, and your sternoclavicular joint. We oftentimes call this the SC joint, the AC joint. And we also talked about joint types. There's 3 major joint types, and these are important. Your first and least mobile joint type is these fibrous joints. So in this middle of this diagram, these are 2 examples of fibrous joints from these syndesmosis between your tibia and fibula. This is kind of the high ankle. There's actually a couple different ankle joints, and this is the high ankle. This is should be an immovable joint. Also, the sutures between skull bones are also fibrous. Slightly more mobile than that are cartilaginous. This is what you find between your hip bones, between your pubic bones, pubic symphysis. These are also the fibrocartilage disc between your vertebra, and there's slightly more flexibility in cartilaginous joints than fibrous joints. Synovial joints are the ones we're going to spend the most time talking about. So again, 95% of the points and the energy is spent here in synovial. This is from the ball and socket joints in your shoulder, your glenohumeral joint, to this looks like a hinge joint at your humero-ulnar joint, to these biaxial joints. So maybe helpful here on this slide is multi-axial, the ones that can move in 3 planes: sagittal, frontal, and cross-section, transverse section. Uniaxial, which is just 1-dimensional, and biaxial, which is 2-dimensional, 2 planes. So those are 3 big categories of synovial joints. Jumping into each one of them in particular, you'll actually see in this color diagram, in red, it's non-axial, are the ones that don't really move in any plane very much. Uniaxial, like the hinge joints, hinge joint of your elbow, your humeral ulnar. These radio ulnar joints are also uniaxial. To biaxial, which are here in the hand, and multiaxial, which is the ball and socket joint. So again, in the upper extremity, the only multiaxial joint is the glenohumeral. From plane joints, this is between your carpal bones. This is like these intercarpal joints are plane joints, as well as these carpo-metacarpal joints are also plane joints. They shift up and back a little bit, but not very much. To the hinge joints that are in your humeral ulnar, also to your interphalangeal joints are also hinge joints moving in one dimension, so that's uniaxial. To these pivot joints, which also are uniaxial. The pivot joint, great examples would be both of your radio-ulnar joints that pivot when you do supination, pronation. We'll talk about that in a second. Your condylar joints, guys, mean U-shaped joints. So condylar joints would be between your metacarpal bones and your phalanges. So your metacarpophalangeal joints are condylar. As the finger moves across, it kind of creates a U shape. And so that is a condylar joint. Just like my wrist, my radiocarpal joint is also a condyloid or condylar or condyloid joint. Both of those are fine. Your first carpometacarpal is special. It's a saddle joint. It's biaxial and allows the thumb to do a couple of cool things. Part of the reason why our species has such amazing manipulation powers in our hand is because of the saddle joint creating opposition. So we have opposable thumbs. And then lastly, the ball and socket joints. There's only two types of this, your glenohumeral joint and your hip joint. This is multi-axial because there are lots and lots of planes that it can move in. So these are all synovial joints. They all have synovial membranes. They all have synovial fluid, which reduces the amount of heat, reduces the amount of friction, absorbs that heat away from these joints that move a lot. And so we move these a lot, that we injure them a lot. They're really cool. Okay, so let's keep moving. And again, table 5.3 in your book has a summary of those three types. Again, synovial is the one we're spending the most energy on this unit. Now we're moving on, guys, from not bones, not joints, but we're going to talk about joint movement. So joint movements, there are 8 different categories of joint movement. I'm going to try and act these out as best I can. So in flexion and extension, you find that you have a decrease in the joint angle. So again, looking at my glenohumeral joint here, I am decreasing the joint angle up to 90 degrees, all the way up to here, so I'm flexing. And I might be able to go into hyperflexion as I go behind my head. So flexion, I'm decreasing the joint angle. Extension, I'm increasing it to 90 to 180, and I'm hyperextending it as I go back. So flexion, hyperflexion, extension, hyperextension. Same is true in my elbow and my interphalangeal joints. So my humeral ulnar joint, I find that I can flex this thing to 20 degrees of flexion. I can extend it to 90 and 180. I can even hyperextend it past that 180 mark. Don't have very much hyperextension. Okay, so that's the first movement. Some mastery ones here would be doing it in the leg. We'll get to this later this year, but you also have flexion with your butt coming up in a butt kicker. I just got a cramp in my hamstring. I'm an old man. So you can flex your knee back, just like she's doing here. Her heel's going towards her butt, so she's flexing her leg. As she extends her heel outwards to level, that would be extension. And then she could hyperextend it. You can also do lateral flexion at your waist or your neck. It's called lateral flexion. So we'll look at this runner at the end. Second type of movement we're going to look at is abduction, adduction. Abduction is really clearly seen at your glenohumeral joints. You can abduct your arms away from the midline. And so if these aliens are abducting my arms away and I'm adding them back to the midline, it's called adduction. So abduction, adduction. You can also do the same thing in my hand. If this is the midline of my hand, I can abduct my fingers away from the midline, and I can adduct them back to the midline. So abduction, adduction. I can do the same thing with my hip joint. Internal rotation, external rotation happens when your humeral head is rotating inward, so internal rotation, and then external rotation outward. I have a lot less flexibility in external rotation. So those two happen there. I can also do that at my hip joint. So this is particular to internal and external rotation, is particular to ball and socket joints. You find a lot of external rotation in athletes like pitchers and volleyball players and javelin throwers. External rotation And the muscles that control the movement in and slow that arm down are a big cause for a lot of injuries that we'll look at this unit. So external, internal. Check. Elevation depression happens at the scapulothoracic joints. When you raise your shoulders up, elevation, when you depress them down, you are depressing your scapulothoracic. Your scapula is moving down your rib cage. That's elevation depression. Again, when I was a hammer thrower, I do intentionally. I naturally did this when I threw the hammer, and I do it intentionally, depress my shoulders to stay in the middle, so I could create a lot of extra force. My body was stable in the middle of that hurricane. So elevation depression. You also have protraction, retraction in your scapulothoracic joints. Your shoulder blades are moving forward and they're retracting backwards. So protraction, retraction in the scapulothoracic joints. You can also see that happen in your temporomandibular joint, your TMJ, in your jaw. You can protract and retract. I look really smart, don't I? I always look smart. This silly soccer player is moving his arms backwards. So when you move your arms backwards, when you interlace your arms, your scapulas are forced into retraction. Okay, moving on. Circumduction, guys, is easy. Circumduction is just drawing a circle. This is really only possible naturally in your ball and socket joints, in your glenohumeral, your hip. It's just drawing a circle, which is a combination of a whole bunch of different movements. So if I draw a circle with this arm, I am flexing my glenohumeral joint and abducting it and extending it and adducting it and flexing it. And so that circumduction is a result of a whole bunch of different motions, and I'm even externally rotating it, internally rotating it, externally rotating it. So circumduction is actually an incredibly complex motion that's really only possible with ball and socket joints. You can kind of do it with your finger, but it's a little bit artificial at that metacarpophalangeal joint. So we move into the last two movement types, supination, pronation, dorsiflexion, plantar flexion. We find that supination, pronation happen in two main places. They happen in your forearm and at your ankle joint. So if I pronate my forearm, I'm going from anatomical position. I am pronating my forearm. I'm actually crossing my radius over so that those bones line up and kind of create a kind of an X. And as I open my palm up, I'm supinating my forearm. Just like with my foot, if I did the same exact thing with my foot, I'd be turning the bottom of my foot up towards myself as supination. I push it down the other way, it's pronation. So I encourage you guys to act that out with your forearm and your foot. My best way to remember this is Oliver Twist asking for more soup. So if he's asking for more soup, he's supinating his arms up to say, please, sir, may I have some more? And he's pronating away. Actually, that's not really a connection to Oliver Twist, just supination. Last one is dorsiflexion, plantar flexion. I say dorsiflexion because sometimes that's one word, D-O-R-S-I flexion, dorsiflexion or dorsal flexion. Both are fine. Dorsiflexion is really what we usually think of as flexion. We would usually think of plantar flexion as extension, as you extend this foot away. But it's just along a different axis, so we say plantar flexion. Both are decreasing one of the joint angles possible. So if I look at this runner, this track runner, I think is a great example. I would pause the video and go ahead and analyze her joints, especially her arms and her elbows and her wrists. What is she doing in each type? But her legs also are really moving in one plane. You can analyze these motions pretty well. So at her right glenohumeral joint, she is hyperextending her right glenohumeral joint backwards. She's flexing her right humeral ulnar joint, and she is abducting her metacarpophalangeal joints. Those are moving away as she's sprinting like that. As she brings her arm forward, like her left arm, she is flexing her left glenohumeral joint. She's kept her left humeral ulnar joint flexed, and looks like she's laterally flexed her radiocarpal joint a little bit. Her right leg is basically flexed, her left leg is basically extended. So flexion of the hip joint, flexion of the knee joint, flexion, and by dorsiflexion of the ankle joint, versus extension, extension, plantar flexion. So I like that picture a lot. Get used to that picture. I would go down again, practice the joint names, the joint movements of each of these joints. I think it's a great way to practice. The single best way to practice this whole lesson so far is just to look at this picture and name the joints, name the joint types, name the joint movements. That's the best way to come in and practice with me also. Also, we talked about different muscles. These are the 16 muscles. There's one more muscle here called the subscapularis. It's not included because you can't see it here. Teres minor is this guy right here. This is the infraspinatus, supraspinatus. Those are 3 of the 4 rotator cuff muscles we'll look at first. There's also the rhomboids right here and here. The trapezius is this guy, usually what guys and girls who want big neck, big shoulder muscles up into their neck want to go for their trapezius, helps you pull things up. To your deltoid, this big bully of a muscle, your deltoid. To your pec major, which is on the front, so you can't actually put this muscle on this diagram. To your elbow movers, which is your biceps brachii, you have 1, 2 heads here. So bi means 2. So biceps brachii. That's usually what guys like to have with these big muscles here, biceps brachii. Triceps brachii is on the back side, this dorsal view. There's 1, 2, and a hidden 3rd head. So triceps. There's 3 heads to this guy. That's your triceps brachii. Helps you extend your humeral ulnar joint. Your supinator is underneath these muscles. You can't see it. That helps you supinate your forearm, kind of pulls from the back to the front. So that supinator must be on the back side, the dorsal side of my arm. So it pulls my arm over. To your pronator teres, which is this guy right here, kind of dives under there and you can't see anymore. So that's your pronator teres. He helps you pronate your arm. So you grab your arm and he grabs your arm and pulls it back over to the front. So he's right there. All the way to these muscles, palmaris longus is this guy, this big band right here that expands here. If you trace that backwards, that's your palmaris longus. You can actually see mine right here. That's my palmaris longus tendon. 10% of people don't have that muscle. Weird. Some people have it on one side, not the other side. We'll talk more about the muscle later. Adductor pollicis means thumb. So just point an arrow for here for now. We'll do specifics later. Opponent is digiti minimi. The digiti minimi is all of the muscles that go to the pinky finger. It's the smallest. It's the minimum. It's the smallest finger. So just put an arrow there. We'll go over specifics later. Extensor carpi radialis longus is also in this group of muscles. Hard to see also in this diagram. So I'm sorry for lame diagrams here. We also talked about we had you guys label the nerves, this whole set, this whole interconnected web of nerves up here in the neck, extending down through the clavicle, behind the clavicle, is the brachial plexus. We had to memorize all of those sections in college. Ulnar nerve runs along the ulna right here. The radial nerve, that should be an L at the end, radial nerve, runs back here. It's kind of free hanging back here, versus this median nerve running down the main section of the hand, median nerve. And your carpal tunnel, guys, just circle this area right here. It's actually the tunnel where your median nerve oftentimes gets pinched. So just circle that area and say carpal tunnel. It's not actually a nerve, it's just an area that the nerve passes through. Arteries and veins are here. So subclavian goes behind the clavicle. Axillary is in that same axillary region, so it's in your armpit. So axillary artery runs here. It's the same artery then turns into your brachial artery. So we just call it the same structure, a different name, depending where it is. So brachial. Sometimes they use cubital artery to describe this area before it breaks off into your radial and your ulnar artery. That's all the arteries I want you to know. I don't want you to know all of the little dirt roads that you could memorize. Just know subclavian, axillary, cubital, radial, ulnar. The veins are slightly more. There's also a subclavian vein. Proximal to the subclavian vein is this brachiocephalic vein up here. So the part you can see above the clavicle is brachiocephalic. It's this big, thick, short section. Then subclavian. That also goes to your axillary vein before it breaks off into 3 sections. And so you guys follow me? These 3 right here, basilic, brachial, and cephalic, these are in alphabetical order. Do you guys see that? B-A, B-R, C-E. So this is the basilic vein. This right here is the brachial vein, and the most lateral is the cephalic vein. So BA, BR, CE, and those are those 3 veins. Before you get to the median cubital vein, one of the most common sites for blood draws is this median cubital vein. And also similarly named radial vein and ulnar vein here. Again, that's all I want you guys to know for this unit. Okay, last piece, guys. I know we're at 20 minutes, but this is the last piece of the overview, or some muscle conjectures. So muscles overall, guys, you have 640 to 850, depending on how you want to define what a muscle is and what's a separate muscle from another muscle. We're going to do a demonstration in class using a tennis ball, and I'm going to give yourself a really cool foot massage. Because muscles, even though they have different functions, muscles act as a unit. Muscles have a huge interconnection. There's a whole bunch of stuff called fascia that connects the muscles together, and it's really hard to separate out the muscles into these distinct, nice, neat categories. So muscles, even though you have all of these, despite that, they still act as one functional unit. It's your muscular system. It's one organ system. Muscles, guys, muscles, tendons, ligaments. Ligaments are separate structures from muscles and tendons. Tendons are just where the muscle body narrows down and attaches to a bone. So there are tendinous attachments, but there are also fleshy attachments. So tendinous attachments, like you see on the biceps brachii, this white stuff usually shows a tendon. Same continuous structure of the muscle. Tendon, and then on the bottom it has a tendon. So tendinous attachments. And there's also fleshy attachments. So in this example of the rotator cuff, you have a tendinous attachment up top here for this is the infraspinatus. You have a tendinous attachment up top. It narrows down and attaches to the humerus. But you also have this fleshy attachment in the back. It does not narrow. The muscle body just implants, just embeds on the body of the scapula. And so that's what we find in all sorts of muscles, that there's tendinous attachments like your biceps brachii. There's also fleshy attachments like your rotator cuff muscles and your glute medius, your glute max, those kinds of muscles. So two types of attachments. We also find that every single muscle has to have at least two attachments, and it has to cross at least one joint. So imagine with me that you have a muscle that's attached from one bone, your humerus, just to your humerus. So one attachment. That would move nothing. If that muscle was attached from here to here on the same bone and it got shorter, it would move nothing. So it has to cross from one bone to another bone, so at least one joint. There has to be a cross in articulation across a joint. It can have more than two attachments, like your biceps brachii has one attachment here on your scapula, one attachment here on your humerus. It also attaches down, I'm sorry, this is the triceps. Your triceps has one attachment here, one attachment here, one attachment on the backside. This white thing underneath is a third attachment, so triceps. It attaches down here on the ulna. So it goes across one joint, since this is an attachment here, crosses this joint, your glenohumeral, and it crosses your humeral ulnar. So it actually crosses two joints. So we expect the triceps to have a ton of functions. It's going to move a lot of stuff. And there are 1, 2, 3, 4 total attachments. One on the scapula, 2 on the humerus, 1 on the ulna. So that's a complex muscle. Also, the longest muscle in your body is this sartorius right here. It actually attaches from your ilium on your hip bone all the way down across over the top and down onto your tibia. So it crosses one joint, your hip joint, and it crosses your knee joint, 2 joints. And it has 1, 2 attachments total. Muscle rule number 4, muscle conjecture number 4, is that muscle actually changes the shape of bone. Over time, the more your muscles pull on your bones, the more those osteoblasts are active and actually build up the size of that bone. So your tibial tuberosity, you can actually feel on your shin, the tibial tuberosity, this big massive bump on your tibia. And the reason why is all of your quad muscles are attached through over the top of your patella to that tibial tuberosity. So when you jump, your quad muscles on the front of your leg are contracting, and all that force really gets pulled through your tibial tuberosity. So those osteoblasts feel that sensation, and they keep building that bone marking to be bigger. So muscles affect the shape of bone, affect the shape of your skeleton. Another conjecture, muscle conjecture number 5, is that muscles contract and get shorter. That is their function. If a muscle like my biceps brachii is contracting and getting shorter, that muscle, my muscle cannot push on my humerus, it must pull. So I could say muscles pull and get shorter, that would be okay too. But my biceps pulls and gets shorter, and that muscle tissue actually builds up into my tiny little biceps muscle here. And if I'm doing this, my muscles are still contracting. So it's possible, the one exception here, my muscle can lengthen if there's a greater force pushing on it. But the goal of this muscle contracting is to shorten it or to slow the lengthening of it. But a general principle is that muscles contract. They just pull. That's all they do. Muscle rule number 6 is that the insertion moves and the origin doesn't. Okay, what do I mean by these words? You have a review of previous muscle principle, guys. Let me go back a little bit. There has to be at least 2 muscle attachments for this muscle to do anything. So again, triceps has 1, 2, 3, 4 attachments. We use the words origin insertion to name the proximal and distal attachment sites. So follow me, guys. The sartorius here has its origin on the hip bone, and it has its insertion on the tibia. So proximally, the origin, you find the origin, and distally, you find the insertion. So those are just descriptions of the kind of attachment you find. So the insertion moves, the origin doesn't. Again, in this model, to go back to that same muscle we were using earlier, this is the origin of the infraspinatus. This is the insertion of the infraspinatus. As this muscle pulls and gets shorter, you find that the insertion moves, it pulls back, but the origin does not move. This thing is stuck. This origin is stuck, and only the insertion moves. So the infraspinatus really just moves the humerus. It doesn't move the scapula at all. This supraspinatus muscle right here does not move in its origin, but it does pull on the humerus and pulls it into abduction. Since this is on the top of the scapula, it pulls that arm directly outward into abduction. So it's only moving the humerus. Whereas what you find in the trapezius muscle, the trap, is that the origin attached to the spine doesn't move, but it's attached to my scapula. So as it pulls, as this top portion pulls, it actually pulls the insertion towards the origin. As the middle portion goes, it pulls the origin towards the insertion. And you can kind of deduce the function of these muscles just by looking at where the origin and insertion are. Another one, guys, another muscle rule is that flexors decrease the angle of the joints and extensors increase the angle of the joints. That's, again, another muscle principle that you'll find. So flexors decrease the angle. Flexors on the front of my body will decrease the angle here, where extensors on the back of my body extend me back up into that Superman position. You guys are, if you imagine me on the floor, flexing my body down or extending my body back up. Also, you find that my bicep is a flexor, so it decreases joint angle, or my tricep on the backside is an extender. It extends my humeral ulnar joint. So it decreases angle, increases angle. Only 2 more, and we're done, guys. We're almost done. So what we find in muscle rule number 8 is that muscles actually work in opposing pairs. So my biceps and my triceps, like I just modeled, were an opposing pair. The biceps flexes, the tricep extends, and so they're actually kind of like opposite. My bicep doesn't extend my arm. I need an opposing pair on the opposite side of this joint. So my biceps functions on the front to flex. My tricep, I need another muscle on the opposite pair, the opposite side, to extend my elbow joint. I want to mention something here that we'll talk a lot about too, is that every muscle has 2 kinds of contraction. One is concentric and eccentric. This I would write down. Concentric contraction is when it pulls and gets shorter. Eccentric contraction is when that external force is greater, and that external force causes your muscle to lengthen. So when I first started doing pull-ups, actually really at the end of high school, early college, when I had to for my track at U of O, I couldn't actually do very many pull-ups concentrically. I couldn't actually pull myself up very well. I wasn't really strong enough, and I was a big guy. I was 230. But if I started up high, I could let myself down slowly. So when I was letting myself down slowly, I was still working on the same muscle, but that muscle was lengthening as I was lowering myself down. So this is my bicep contracting eccentrically, where pulling myself back up, which I was eventually able to do a lot of, was concentric. It was shortening concentrically, and it lengthens eccentrically. And those we'll talk about a lot because that has a huge impact on injury. When you run downhill, when your muscles are working eccentrically more, you're actually more likely to get tired, be sore, injure yourself. So concentric, eccentric. Last rule is striations. Striations are the lines that you see on this trapezius muscle. All these lines, these distinct lines, are like noodles, are like big tubes of muscle tissue, And we'll learn more about sarcomeres and how the muscle is built later this year. But it really feels like noodles. And striations, guys, always point towards the origin. So these muscle striations, you'll find, like this guy, you can actually almost see his muscle striations in his pec major right here. That always points back towards where it originates. The insertion points towards the origin. The insertion moves towards the origin. So striations, those lines actually tell you kind of what the muscle is going to do. Without looking at your notes, try and brainstorm as many of those 9 functions as you can, those 9 conjectures, muscle conjectures. And one way to quiz yourself here would be, we're going to do this in class, is can you reply to these statements? They might be right, they might be wrong. Part of them might be right, part of them might be wrong. They might be totally wrong. So muscles push and pull bones to control your movement. 2, muscles always narrow into tendons which attach to bones. Is that true or not? And 3, I have about 700 muscles in my body, each with its own distinct function. Is that true or not? That's all I got. See you guys.